And there we go. So we are now on and recording. And so one other slide, the thing I'm looking at now, the first one I'm looking at is the very end of 18. If you didn't get to listen to it, I went through all these special flows and the different responses, these different controls, much of which you've heard in different presentations before. And the only thing that is really left now is just to look at a little bit about the dynamics of the capillary. And then you're pretty well done with a few little odds and ends with a chapter on basically blood vessel physiology. And it'll tie in with the cardiac physiology. It'll be relevant to the blood that you did before. I think I'm missing one of the take-home lab midterms. And so we need to, but all the rest of you got them. I post you saw the grades. So they were okay. Okay. So this is the whole idea. We understand it's faster in the aorta and slower in the capillaries. And so it's all about, as they get smaller and smaller, as you would imagine, the flow slows down. And once they get through the narrowest portion where the exchange takes place, by design slow, the capillary beds, then it begins as the vessels start to get larger into venules and then veins, then the flow accelerates. And so, and without that, the capillaries have the largest area. When you look at the aggregate total cross-sectional area of all the capillaries. And so it's all about adequate time. And we really have an abundance of time, just like when we get to the pulmonary circulation. It doesn't take very long to oxygenate the blood, yet we have multiples of that time. So it's that wonderful system of safeguards that we have. It can sometimes backfire on us, but that's another lecture. So I mean, here they're just showing you the total cross-sectional area versus the total velocity. You can see the reverse proportionality that's there, and the whole idea of how it moves. And again, you might remember anatomically these little areas called pre-capillary sphincters, little bits of smooth muscle that could either divert blood away or make sure blood passes through the capillary. So assuming that blood's going to pass, if it's going to divert, it's going to divert. But if it's going to pass through the capillary, then we begin to understand the physiology of the exchange. And it's very much pressures. And there's two opposing forces. Effectively, there's blood pressure or hydrostatic pressure, the force of the blood not only flowing through in a horizontal sense, if you want to think of a blood vessel I'm holding up this way, but pushing in all directions. And I've drawn that for you before, because pressure is the force it's exerting on the walls of the tube, whatever the diameter of that tube that's traversing the area. I don't think you get to use the word traverse in a sentence. So as it goes through that area, that's hydrostatic pressure. What opposes that, remember, once you get to a capillary bed, there's tiny little openings, with the exception of the blood-brain barrier, and what you'll see is the blood-testicular barrier. Other than that, normally fluid would just come out in large amounts. We have something that opposes it and holds a percentage of the fluid in. That's called colloid osmotic pressure. The proteins which can't fit through those little openings are holding on. That's what a colloid is, protein exerting an internal or bring it back in kind of a tug. So they're opposing forces. So effectively what happens at the start of the capillary bed, the hydrostatic pressure overcomes the colloid osmotic pressure, fluid goes out. With all that fluid going out and whatever it contains, nutrients, oxygen, etc., begins to lower that hydrostatic pressure. You're going to see it. I'm just explaining it here. And by the time it gets back coming home, all of a sudden now the hydrostatic pressure is lowered because of the absence of fluid. The proteins are still there holding on to it. So the net force, it pulls back in the fluid with waste products, with carbon dioxide, etc. That's how it works. So it's this wonderfully designed system that as long as we have an adequate amount, and that's what the chapter's all about, an adequate amount of blood pressure, everything works well. Any things that, there's a zillion things that can impact it, whether you're in a position for a long period of time and you're not moving, whether you have a pair of socks on your calf that's cutting in, all of these kinds of things. If you have an injury, anything like that, think of it. So those precapillary sphincters, basically are kind of opening and closing the passageways to where we want to direct the blood. And so all of this, and it's all about their concentration gradients. That hasn't changed anytime soon. So these are the different routes. So they can go right through the membrane, as you might guess, lipid-soluble molecules, and particularly the oxygen dioxide exchange. We already knew that. Tiny clefts, water-soluble molecules, all the different nutrients that are, if you think of it, outgoing or waste products that are incoming, that are able to be water-soluble, are able to do so through those openings. In certain areas, there are larger openings. Remember when we looked at the kidney, bigger holes, we call them fenestration. Fenestration is a window. And again, for water-soluble solutes. And then, of course, active transport, depending on whether we need to do that. You can see in some selected systems that are there. So, and we've seen this illustration before, your typical capillary, how water, the tight number of tight junctions and their proximity can impact the presence or absence of the little pores, can impact it. The little intracellular clefts can impact it. And you can see those capillaries are around the diameter of a typical red blood cell. And they're just showing you the different kinds of movement that they could have, all fine. Nothing special about that. So the fluid, as I said, goes out at the arterial end and comes back by the venous end. Okay? And really, this is an important area when we're thinking of fluid and things that are there in the spaces. I mean, the frame, it's hard for you to relate to it because it's unlikely unless you were injured in sport where you have a swollen leg or a swollen ankle. If you sprained an ankle, you got a lot of fluid in there. But your age is, that's all going to go away. Sufficient amount of physical therapy, whatever has to be done, whatever kind of treatments you're done, be fine. As you get older, it doesn't work quite so easily. Things kind of stay there and make the changes or become long term. And so the fact when there's excessive amounts of fluid in these areas, it limits the amount of oxygen and carbon dioxide exchange. That means tissues are less viable. When there's damage, they are more likely to be damaged severely, predisposed to infection, healing delays, etc., etc., etc. That's what goes on. So a lot of this is something that's more tangible, I think would be the best word for that, for someone who is, as they're aging, someone who long-term, I mean, it depends on what your job's going to be in life. You're standing on your feet all day long. It ain't easy. By the same token, if you're sitting on your posterior all day, the opposite applies. Then you're not getting enough activity. You have to supplement it in that regard. So all of these are part of it. So the fluid flow across those walls causes continuous mixing of fluid between the plasma and the interstitial fluid, maintains the environment, and here are the factors. Blood pressure, and this is what the chapter's about, hydrostatic forces, blood pressure, colloid osmotic pressure. So they exert opposite each other. Now, the hydrostatic pressure forcing fluids out at the arterial end, 35. But by the time you get to the end of a typical capillary bed, it's cut in half. Now, is there some fluid in the interstitial fluid that's pushing back? Sure. But it's nominal. Maybe we're talking about a millimeter of mercury. On the other hand, the colloid osmotic pressure in the capillary, another term we use for it that you hear is called oncotic pressure, and that's pulling back, or they call it the sucking pressure. I don't know, it's such a great way to describe it. It's all about plasma proteins. Remember, when you go back to when we analyze the blood, there's a fair amount of proteins that are in there. I mean, and those proteins, whether it's albumin, whether it's globulins, whether it's the fibrinogen, they are all still proteins. They're all exerting a ton. That's on there. And you can see That's about 26 millimeters of mercury. And yeah, there's another thing, pressure, interstitial fluid colloids, because there's proteins there. So that, I mean, and you're going to see that this pressure, the osmotic pressure in the tissues, and the so-called interstitial fluid hydrostatic pressure kind of oppose each other a little bit, but it's negligible numbers. And voila, we look at what happens. The net fluid out at the arterial end, the net fluid flow in at the venous end. So it either filters through, the way they describe it, and I really don't care about the terminology, or gets pulled back in, they call it reabsorption. More fluid leaves than is returned, and then that's where the lymphatic system comes in. Because a lot of the waste products, a lot of the end products, as well as waste products and some of the end products, basically have to be carried by the lymph because they're just not compatible to be absorbed or dissolved within the plasma. And we looked about that when we looked at the lymphatic system, particularly in the last term, that are there. So these capillary beds, and again, the control of the sphincters here are determining whether you're going to have flow through them or whether it's going to be bypassed or not. And they're constant, all of these capillary beds, effectively all is the easiest way to say it, have a variety of these tiny lymphatic channels available there as well. And they're showing you the, doesn't matter, pushes or sucks, who cares? Stupid. Better diagram. Hydrostatic pressure, 35 out. Colloid osmotic pressure, 26 in. Net of 9. You know, these maybe make a millimeter one way or the other. So in this case, because some of the proteins in the interstitial fluid are pulling it out of the capillaries, the net filtration pressure is 10. Effectively, the stuff goes out. And yeah, oxygen will follow concentrate. Just basically nutrients and things dissolved. The flip side, when we get to the venous end of the capillary bed and we're starting to go into venules, now you have the 17 pushing it out, but by this time with the excessive fluid in there, with the absence of fluid in there, effectively the osmotic pressure has increased, pulling it back in. And again, these don't play a terribly important role. So even if the net is 8 in the opposite direction, they refer to as -8, it's going to pull back. Effectively, that's what's going on at a capillary level, looking at the pressures. So what happens when something goes wrong? Is there too much being pushed out? Is there not enough being pulled in? What are the reasons behind it? And we get to this terrible word, edema. Edema is basically, just to show you, I'll flip back and I'll show you, never we show you this picture. That's called pitting edema. There are two types of edema, pitting, and pitting is just what you see here. You take an area typically over the lower extremity, there could be any extremity where it demonstrates itself the most. You take a thumb over a bony prominence, whether it's the dorsum of the foot, the medial malleolus, lateral malleolus, maybe down, pick some bony area that you're familiar with anatomically, and you put the thumb in there, and you see basically how long that indentation comes to fill it. Yes, sir. What happens if you have to be careful not to. I mean, are you saying when you're doing the examination? Like I'm saying, with something skin on. Oh, that's a problem. Because the fluid, you have to understand that mass of fluid, oxygen and nutrients don't flow through particularly well. It's a very good question because it raises the point, what happens in an edematous leg? They don't heal well at all. Because, I mean, effectively, it is almost by definition with all that fluid deoxygenated, relatively speaking. And without that, it's not going to heal. And when we see this in combination with someone we call chronic venous insufficiency, maybe they had a blood clot years ago. Maybe they have terrible varicose veins that are leaking all over the place. Maybe they have a tumor sitting on that side. Maybe their kidneys or heart are going bad. All of those are the kinds of things we look at. So I would treat those patients. I treated tons of lower extremity ulcerations. And when you see somebody already with a leg that's compromised, it's like, oh, they come in, oh, I cut myself. I scraped myself. The dog stepped up. The kid ran a bike over me, my grandkid. It's like, oh, it's one of those, oh, we're going to have a headache here. I just know it. You got to really get busy on those. The difficulty from a treating perspective for someone like me, whether it's a physician, physician's assistant, nurse practitioner, doesn't matter. Anybody, my family member is like, oh my God. A lot of times they don't, well, I didn't want to bother you. Sometimes they don't want to bother you as an older person. You've got busy lives. And the other one is they don't want to go and be told by whoever they see, you're in trouble. It's such a freaking minefield. It's a very thought provoking situation. So one of the ways we can determine the risk and what we have to do is to see, and usually it's between zero if it doesn't, if there's no problem with pitting, it feels almost instantaneously, like you or I would if we had typically a mild ankle sprain, it wasn't real bad, versus +4. I mean, +4 is you can go out, run to the bathroom, come back, oh, still filling. It's like it's still there. It's kind of like the truck I got behind at Sam's Club. The cab of one of the, like, that pulls a semi, 50 gallons diesel. The bill was $250. Holy, I'm like, what the heck? So I'll back up and give you the school on this. So anything that causes edema. So we look, first of all, this is a vast amount of experience. The first thing we look at when you look at somebody, whether it's all, oh, look at my legs are all swollen, or my feet are all swollen, is it the same on both sides? If it's on both sides, you have to look for something central that's a problem. Heart, kidneys. If it's one-sided, now, I fell and twisted my knee. We have an explanation. If somebody's pregnant, frequently the left side of the leg. Babies tend to, during gestation, are more left-sided than right-sided. I don't know why, but it is. So we were taught. So we tend to see that, and we often see a lot of edema, and we see even post-pregnancy because of the pressure on the veins. They used to call it milk leg. Somebody after they would deliver, and then when they were beginning to lactate, they would all said their leg was up. This must be a milk leg. Old-time terminology. But when it's one-sided, sometimes there's an obvious explanation. You hope there's one. If it's not, then you got to worry something's pressing. When I think biologically something pressing, the first 63 things I think of are a mass. Now you're, as they used to say in Star Wars, you're connecting with the dark side. Yeah, but those, you can't ignore those things. You have to do it. So these are all, and so these are some of the ones I was most familiar with. Vein problems. People who either had deep vein clots or varicose veins, localized blockage. Now it's the heart failure. Maybe there's just an excessive amount of volume. All of those things, something is creating this imbalance. It doesn't have to be those factors. Why it has to be treated is the longer it's there, the proteins that are in that area are going to latch on and hold on to that fluid, and it's going to become firm. It's going to go from pitting to non-pitting. Non-pitting edema is something where pitting edema has been there for a long time, unless it's some other condition. Some people are born with or develop conditions that, because of their faults in their lymphatic system, where they're always swollen and they unfortunately don't get better. The classic example, are you familiar with, it's coming, Kathy Bates, actress, won an Academy Award in 1990 in an early role, which was a very muscular, chunky lady in 1990 with a Stephen King book called Misery. It was a great movie with James Caan. She has done so much work over the years. She was in American Horror Story and all that stuff. Really, now getting ready to end her career. Brilliant actress. She had breast cancer. They did a lymph node dissection. Her arm was so bad. Typically, it's on the left more so than the right. Whichever breast affected hers on the left. That every day before she could go to shooting, she had the lymphatics were so bad she got lymphedema. They had to mechanically pump it out in the morning, get a sleeve on there so she could go work like 6 days a week. And she always would wear long sleeves. They know how to make that. It's fascinating stuff. This is one of the real problems associated with the lymph node dissection. So the trouble is if it's not treated and it's pitting edema and it's able to be treated, if not, it will convert. And we saw a lot of these cases. So this increase in the fluid osmotic pressure, inflammatory response could do it. Twisted ankle, some localized inflammation, maybe some type of systemic infection pulled into the space. So those are things. Hypoproteinemia, low levels of proteins in the blood. Where do we see this? Malnutrition, liver diseases, again, kidney problems. Remember the classic malnutrition. Malnutrition, you see these little kids that had spindly arms and spindly legs and big bellies, and it was all filled with fluid. It was called ascites, A-S-C-I-T-E-S. The fluid would extravasate. There's no protein to hold it in. Everywhere there was a capillary bed, and it would start in the bellies, and it sometimes worked its way into the legs. Some of them are lymphatic. The fascinating disease, elephantiasis, has to do with a bite from a particular fly. I think it's tsetse fly. And it carries whatever protozoan pathogen. Basically, what it does is it lodges itself in lymph nodes and creates lymphedema. So it fills and gets firm, and really a person's leg over time looks like an elephant's leg. So if you want to, you can Google elephantiasis. It's scary. But it's only, it has to do with it. It's only in particular, it's African because of the nature of the flies and the nature of the disease entity that the eukaryotic pathogen that they're carrying. And forgive me, my name escapes me. So a lot of things that are there. So generally pitting, all the things that look what happens. This is more to your question. Diffusion of gases, nutrients, waste, all of this type of stuff that are part of it. And that really concludes it with regard to the blood vessel aspects in physiology. It's part of what's intertwined. And so now we're going to go take a look at the heart, because remember we did that in class with the electrocardiogram and all that. This is what follows afterwards. And I think it's really important for me to show you the single most important thing with regard to how the heart works. So I'm going to X out of that. Something before my voice goes, and hopefully take the last 20 minutes or so that we have in this before we move on and get to that part of the heart. And I really think the important part of me is to show you. We did all the arrhythmias and that stuff, and blah, 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 and the tracings. It's really to start. I want to get you down here. I'm going to come back. All these different factors. It's coming. Did I pass it? Oh yeah, baby. Here it is. Cardiac cycle. This one slide is sufficient probably to know what's going on in the heart. The only thing they have, and they took it out, I don't know, in the older editions they used to have where we had the heart sounds associated with it. The whole idea is that electrical events precede mechanical events. So as we look, these are just some of the mechanical events. Systole, contract, diastole, relax. The cycle is basically what goes on. Atrial systole, then diastole, followed by the same in the ventricle. and we reflect it in different pressure, not just your blood pressure, but different pressures and volumes that are in the chambers of the heart in particular vessels. So we have to look at why our blood flow is so nice and regular, even though we feel a pulse. Okay, our blood flow by definition is pulsatile, but it's not in a regular pulse. Sometimes when you feel those, it's startling. It's all about being able to have a relatively smooth flow comparatively, and that's where the cardiac cycle is. So we can understand the mechanical events which follow electrical events, and they always do. The three phases. So we start with what happens as the heart is relaxed. Pressure's low, 80% of the blood is flowing in. At that point, the aortic and pulmonic semilunar valves are closed. The atrioventricular valves, right and left, are open, and the heart's filling passively. It's coming back to the heart, goes right from the atria to the ventricles. Thank you very much. At atrial depolarization, that P wave that you saw is the electrical signal to start the atria contracting intentionally. We take our time and make sure that we top off the tank, as I like to phrase it, with that last 20%. A whole 24 milliliters in each chamber. And at that point, we have what's called the end diastolic volume, the blood in each ventricle at the end of that phase. And so at that point, as it finally gets through that AV node and we get the bundle rapid, and then it's going to polarize, and then we're going to end up, the atria by that time will finish contracting, and at the same time, the ventricles are starting. Very aggressive. So what happens initially is the ventricles start to contract, the fluid, the pressure builds up, and then it causes those atrioventricular valves to close, and they call it isovolumetric contraction. Super important, because at that point, not only are the pulmonic valves closed, but the atrioventricular valves are closed. So it's a split second where everything's closed, and what you're doing, since your pressure is increasing, the volume remains constant. So the pressure increases enough to overcome whatever back force there is in the aorta and the pulmonary artery and force them open. And the aorta eventually reach typically 120 millimeters of mercury. That's when we begin to see ejection. Okay? And at that point, now they start to relax, and we see what's left, the end systolic volume. What's remaining in the ventricles? The ventricular pressure drops, and what happens is you're going to see some backflow, and it's what I described to you before, is that trampoline effect in those big conducting arteries like the pulmonary artery and the aorta. As the pressure begins to drop, okay, at that point, those big trampoline-like elastic connective tissue will rebound and create that backflow that will push the aortic and pulmonary valves closed, and now the ventricles are completely closed, and at that point they begin to relax. And eventually what will happen is they continue to relax, the atrioventricular valves will open, and it will start the cycle again. You're going to see here this phenomenon, the dichrotic notch. The dichrotic notch has nothing to do with electrical activity. That is the pressure wave in the aorta. So you can put a catheter in there, you can put a sensor in there, and that's why they've done it. And effectively, you'll see what will happen. You'll begin to see the pressure will start to dip. Once those valves close, you get a little, it'll do the whole thing again. Effectively, rather than having very, very pulsatile flow, effectively on average, this is relatively easy. Even wasn't that we sustain consistent pressure so things will flow all the way down. Just on a certain amount of velocity to bring it back. That's the beauty of what that dichrotic notch. It's all about the elasticity of the aorta and the pulmonary and other big arteries like the carotids and the subclavian. By definition, conductive arteries, and that interesting phenomena of backflow. You'll see that. That's kind of what I'm driving at here for this. And as you can see, time-wise, on average, 75 times a minute. Whole cycle about 0.8 seconds, kind of like when we looked at Jenna's, EKG and got that. You're in good shape. You're going to make it to tomorrow. And so you can see the atrial phase, not that long. And this is not the electrical, this is the mechanical. 1/10 of a second, 3/10 of a second, and it's quiet. I mean, the heart's got a great job description. I mean, once it's done, it's got the rest of the cycle off. And so what we see here is all of this, and knowing it's hard because it's not. I mean, you can blow up the diagram like I could. Here in green, you have the pressure in the aorta. So if you follow the green, what happens? The aortic pressure begins to dip as we get to complete, even for initiating the next aspect of the cardiac cycle. I'll explain it to you. If it goes up, then we see as it starts to unload. In blue, you have the volume. So here's the volume in the ventricles. Slowly, steadily filling just a little bit. Okay? So you can begin to see that. All of a sudden, when the cycle starts again. So here, you can see the start of the cycle. You can see how rapidly it goes up. At that point, that's that isovolumetric contraction. Pressure goes up and up. The bigger part of the pressure goes up and up. This is pressure, not volume. So red is the pressure of the atria. It stays pretty consistently low. Pressure in the ventricles increases when it gets top to one. Then you can begin to see that increase. You can see how it drops kind of like a bell curve. But in the aorta, was when we get that dichrotic notch, here, semilunar valves are opening. And here, as the heart now begins to relax, the ventricle empties, it gives an opportunity for the semilunar valves to close. And that's when we get the dichrotic notch. So it's not nearly as bumpy a road. So that's right. When a certain word, making not such a great effort. Now, let's put together. Anyway, so here everything's addressed. The aorta, pressure's going down. Acid filling here is going on, so there's not a lot of pressure. Here you can see in black the volume in the ventricles gradually increasing. You get the start of the P wave as we trace it down. Look what's going to happen. We're going to start to see increased pressure in the atria and the ventricles. Notice we're going to get that little top up of roughly 80 all the way to 120. We follow it down during the P wave and then the completion of the P wave all the way to here. Now it's all filled up like that. So what happens next? Get that QRS complex, the very start of it. Now, rapidly, we're going to get that phase where the ventricles begin to empty. The atria really don't play a pivotal role because a very big part of the ventricle pressures begin to rise. And then, bang, all of a sudden we get it here. That is the opening of the semilunar valves. That's the first heart check. Not big part of the closure of the semilunar valves. That's the first love dub thing. And you have that isovolumetric pressure rising enough, closes the valve, first heart down, and we begin to see this distinctive increase. Finally, it reaches roughly the systolic ejection pressure relatively early on when it reaches it up to or just about 120. And notice, volume will begin to dip rapidly in the ventricle. The pressure will begin to dip. At the same time, once in the aorta, that pressure dips enough that expansion from that forceful exit begins to change. And then that trampoline-like effect or the rebound, as I call it, goes through. Now we get that second wave. I drew it for you before, some time ago, so I'm sure the drawing hasn't changed remarkably since then. Now you have to take any one of these valves like that. Here, let's say it's the aorta. What happens is, now as the pressure rebounded out that way, you get an abundance of flow. When we finally release the pressure, it's like fluid in this tubular system that's flexible. So if we squeeze it back, bang, bang, this way, it'll push the fluid here, slamming the door shut, second heart. And at the same time, the fluid will bounce off that wall, that closed semilunar valves, and it'll have a rebounding effect this way. And that's accounts for the dicrotic notch and the continued pressure wave, rather than being up and down. More of a gentle curve, even though it doesn't look like it. That's the beauty of this system. And all of this is happening. Here's the T wave. By this time, the ventricles have already electrically fired, mechanically they fire. Here, as they begin to relax, all this. And that's why you look at certain areas. We look ventricularly for problems. Here, atrially, we look for problems. So you have an idea where they are from the cardiogram. People say, I realize with scans today, with more elaborate testing, with non-invasive testing, there's a lot of ways that these can be diagnosed, but there's really no substitute, I think, for looking closely at the cardiac cycle. So I'm not quite sure the depth of questions that I will be asking you about that. This is not on, this will be, I guess, in some way incorporated into what becomes the lab final, I would think, down the road. So the first sound, the AV valves closing. The second sound, semilunar valves closing. And the pause, effectively the heart's relaxing during that period of time. Mitral shortly before that. Disclaimer, I can't help you. I do not have the ear for it. I can't hear a valve. I can't hear a murmur. I can't hear any of those abnormal sounds. Just can't hear it. My first wife could hear, oh, there's a gallop in S2. Who the hell knows? Is there a horse in there? I mean, some people have a gift with that. You can hear them online, I am sure, if you're interested. So just not in my toolbox. As you might guess, my wife insists that I have selective hearing. It's a male trait. They'll tell you we only hear what we want. Oh, don't look at me like that. You've said that already. Ask any mom. Yeah, he doesn't listen. And they're just showing where the sound, and that's where you would put the stethoscope here. So what is a murmur? That kind of an irregular sound. We talked about that anatomically. Something wrong with the valve. Is there backflow? Is the valve irregular? Was it from damage that someone was born with? Did they get rheumatic fever or some other infection that might have led to problems that are there? And again, the problem with those is you're predisposed, they are predisposed to, how should I say it? You're predisposed to those kinds of things, potentially blood clots. And because of those clots, tiny clots will form on the valves. Potentially that can be a sign of infection or inflammation. Okay. It's called bacterial endocarditis. With bacteria, which are transiently in the bloodstream, to some extent, almost any time you eat. Certainly whenever you brush your teeth, a lot of times you have a transient bacteria. Just the way it is. You have a ton of blood vessels, you brush your teeth, floss, that type of stuff aggressively. Bacteria get in there. It's not a big deal for most of us. Valves can be too narrow, so they can't open, and you can hear different sounds. That's more high-pitched, they tell me. And then this is the important physiological aspect. Cardiac output. the amount of blood pumped out by each ventricle per minute. This is the minute volume. When we get to respiratory, we're going to talk about minute volume. In the heart, we talk about cardiac output. They have to be equal. If we're pumping out 5.5 liters of blood with cardiac output, we have to have 5.5 liters of oxygen that we're bringing in every minute. The two have to be in concert. If they're not, sooner or later, something bad's going to happen. They always have to be married to one another equally. And so cardiac output, simple for you to know, heart rate times what we call the stroke volume. That 70 milliliters is what we refer to as the stroke volume. It also represents the ejection fraction. You have 120 milliliters average in each ventricle. We pump out 70, which leaves 50. So if you do the math, it's roughly about 57%. That might not seem terribly efficient. Well, why don't we pump it all out? The nature of it, it just doesn't do that. Because the whole idea, as you'll see as we go through this, when we get over to the lab and I explain it a little bit more, the whole idea is that you have to have, the key is when the heart is completely empty, it's too contracted to really satisfactorily eject the blood. It's a problem. It's got to be stretched. It's all that length tension relationship. So, and again, when we stretch a muscle optimally, we get optimal performance. And the heart, if nothing else, is about being consistent and perform. Your heart's supposed to stroke perfectly every time, every beat it ever takes through your entire life. It's just the way the heart is. So I'll take and get into all these regulation of pumping and all that good stuff. But you will obviously need to remember the definition of cardiac output. Your heart rate, typically 75 beats per minute, 60 to 80. The stroke volume, typically 70 milliliters consistently for 5.25. You don't have to do the math. We're not going to be able to do that. I'll leave it there, give my voice a 15-minute break, and come and talk more. You don't have to thank me. It's all